Please start.
Good evening, doctors.
Yeah,
Regards from Bayer Oncology. Thank you for joining tonight's discussion on prostate cancer. Today we have Dr. Sadashivu sir. Sir is the department of head of the department Medical Oncology, Nizam Institute of Medical Sciences, Hyderabad. Sir, over to you.
good evening, everyone. I am Dr. Sadashivu Gundeti. So today's, I think, the webinar, I think, definitely we wanted to learn something on prostate cancer. So I think the prostate cancer is now, I think, ranking third and fourth in the first five cancers now. Once upon a time, it was the ninth, 10th, and now the recent statistics clearly mentioned that one. The prostate cancer incidence is something what you can say. For example, if you take the male cancers, after head and neck, lung, the third one is the prostate cancer is becoming in number three or third rank. So with that, there is an increased incidence of prostate cancer. The reasons are various, but ultimately, there's one of the reasons are the longevity of the individuals. But major interesting point here is again, some people, because of this awareness, they are able to come to diagnostic centers or hospitals with minimal symptoms. So without even having the major, they can say metastatic visceral or something like that. With that, I think people are coming early to hospital, and their armamentarium of these drugs also increased significantly. Once upon a time, only bilateral orchidectomy was the treatment of choice, followed by some bicalutamide or ketoconazole. Now we have so many drugs are there, but how to sequence them? And again, here also, again, we have the subset of the people also, metastatic castration sensitive. Again, we can treat these patients with different agents. After some time, if they become again resistant, they're castration resistant. So even there are so many subsets are there, so many drugs are there. I think better to choose them wisely. With that intention, I think the Bayer wanted to organize this webinar. Thanks to Bayer for choosing us. And definitely, I think we are going to have a nice discussion. The two consultant medical oncologist. One is Dr. G. Muralidhar. He's a senior consultant from Medicover Hospital, Kakinada. And another one is none other than Dr. Y. Rajni Priya. She's also consultant medical oncologist at Mahatma Gandhi Cancer Institute. The first, I think, I'll over to Dr. Murali. Then again, we can discuss some of the issues. Then we'll discuss another trial. Okay. I'm going to present the trial. The third one is the Dr. Rajni, she's going to share her personal experiences. Dr. Over to Murali for your presentation now. Thank you.
Sandeep, is my screen visible?
Yes, sir. It is visible and you're audible, sir. Please go ahead.
Yeah. Very good evening to all. I especially thankful to the Bayer Group for giving this opportunity. Very good evening to my teacher Sadashivu sir and my colleague Rajni and other participants. The next 15 to 20 minutes, I will be discussing about the new treatment modalities in metastatic hormone-sensitive prostate cancer. Sir already explained that now the prostate cancer is the leading cause of morbidity in the elderly people, especially. Coming to the prostate cancer landscape, so majority of patients diagnosed with localized prostate cancers, after some part of treatment, some may be cured, some may be relapsed like with the biochemical recurrence. With the biochemical recurrence, some patient may turn into the non-metastatic castrate prostate cancer. Some may directly converted into the primary progressive hormone-sensitive prostate cancer. Ultimately, all these people, these recurrence people, converted into the castrate-resistant prostate cancer. Finally, there is a terminal death. So patients who suffer and die of prostate cancer will all have a castrate-resistant prostate cancer. This is a very bad continuity of the prostate cancer disease. So suppose if you this majority newly diagnosed hormone sensitive prostate cancer, if you there is a lot of drugs available in the market. If you use properly with various combinations, we can delay the development of the castrate resistant prostate cancer. That is our ultimate goal. Once the patient developed castrate resistance, the survival is becoming very, very less. So we have to more focus and we have to better utilization of all drugs in the hormone sensitive prostate cancer. So opportunity to delay CRPC is our main goal and aim of to improve outcome. So coming to these historical data, if you see in Stampede trial, the main comparator arm is the only androgen deprivation therapy. If using only androgen deprivation therapy, the median overall survival is around 3.5 years. Progression-free survival around less than 1 year. So there is a high chance of progression to castrate-resistant prostate in only ADT arm. So we can now do much better with various drugs to prolonging the life and prolonging the time to converting the castrate resistance. So over the last 10 to 50 years, the treatment of castrate sensitive disease is evolving from simple historical ADT to docetaxel or some second generation drugs like enzalutamide, apalutamide, now darolutamide approval in sensitive cancer. Next, in some patients, in subsets of patients, we can give triplet therapy with ADTs, some second generation like darolutamide with docetaxel. So these triplet therapies are now approved by majority American guidelines and ESMO guidelines in subset of high risk group patients. So compared to the historical ADT, now there is a lot of drugs came into this picture. Previously, in around 2013, the docetaxel is approved. Later, there is a abiraterone is approved. Later, enzalutamide, apalutamide. Now, darolutamide is approved in treating the hormone-sensitive prostate cancers. So, there is a lot of drugs is approved in this segment. So, how can we choose these drugs? So, based on that, first of all, patient comorbidities, his performance status, and financial status, coexisting medical conditions like cardiac failure, seizure disorders, renal failures. We have to take into all of these comorbidities and patient factors to decide the final drug to improve the OS. So plenty of drugs came, but how to choose that is a very, very important. So can we're already known in Stampede trial, one arm is the along with standard of care with radiation. Can we give radiation metastatic cancers in hormones and yes? If you see this trial, the patient has a low volume disease. That means less than 4 bone metastasis. Thus, progression-free survival and OS also improved in low volume metastatic disease. If you see the high volume disease, there is no such improvement. So we can give radiation to the prostate in low volume hormone sensitive prostate cancer. So next drug came into the picture is docetaxel. So it tried in both high volume and low volume. In high volume disease, there is a significant OS improvement with good hazard ratio with significant p-value. There is improvement of 16.8 months in the OS. But coming to low volume, it did not show any improvement. So docetaxel, if you want to use a docetaxel, better to use in the high volume, high risk patient prostate cancers. The next drug came into market is abiraterone. So abiraterone plus ADT, this is the first hormone therapy is showing the good OS benefit. If you see the Kaplan-Meier curves, overall survival is really 53 months with ADT plus abiraterone compared to the placebo arm is 36.5 months. So this is the first hormone therapy showing the significant OS benefit in the hormone sensitive prostate cancer. The next, but what is the problem with abiraterone? We're already discussed. So majority of prostate cancer patients are elderly. They have a lot of comorbidities like diabetes, hypertension, and cardiac patients. So we we are giving prednisolone, 5 mg BD along with hormone sensitive prostate cancer. So even though if you are giving 5 milligrams, so it will produces some adverse events compared to the placebo arm. If you see hypertension grade 3 is increased, hepatotoxicity like AST, ALT elevations, hypokalemia we will commonly seen. So fluid retention. So the fluid retention will cause the further cardiac failures. So this is the main problem with the eberate. Even though it is a good drug, it has some own side effects in the cardiac patients and hypertension patients, diabetes patients. Even 5 milligrams also it will cause a lot of GRBS abnormalities. We are seeing very commonly. So we have to choose very important when we are considering the eberate. So next drug in the market is in sensitive prostate cancer, enzalutamide. This is a novel androgen receptor blocker. It can tried in both high volume and low volume. It had a good hazard ratio and a better overall survival compared to the placebo arm. So it is a highly benefit in the low volume compared to the high volume disease. So next drug and there is the apalutamide Titan trial. It is also showing the good PFS and OS benefits compared to the placebo arm. The good hazard ratio for OS is 0.65. It will be useful in both low volume and high volume. It's significant benefits seen in the low volume patients. So these are all the doublets. Can we combine the triplet therapies for improved outcome? Yes, there is a new trials came to improve the outcome in the some selective subset patients with triplet therapies. So in which patients we have to give triplet therapy? Trials have approved for high risk and high volume prostate hormone sensitive prostate cancer patients. We have to try triplet therapy. So what is the high risk described differently? So at least Gleason score more than 8, at least more than 3 bone mets, and at least 1 visceral mets. It is called high risk. Coming to the high volume, more than 4 bone mets, 1 beyond the axial skeleton or visceral mets. These are called high risk and high volume disease. In these patients, we can try triplet therapy. Triplet therapy, triplet therapy. So coming to the first drug in the triplet therapy is a PEACE trial. This is a PEACE 1 study design. It majority included in the de novo metastatic, not recurrent one. No prior chemotherapy is allowed. In this trial, they chosen both high volume patients and low volume patients. It is a 2x2 factorial design. One arm is the standard of care with radiotherapy. One arm is the abiraterone group. Standard of care in this group means ADT plus docetaxel. So arm A is ADT plus docetaxel. Arm C is ADT plus docetaxel plus radiotherapy. Coming to the abiraterone group, ADT plus docetaxel plus abiraterone. One more arm is ADT plus docetaxel plus abiraterone plus radiotherapy. This is so 2x2 factorial design. So coming to the results. So coming to triplet, if you see this high volume disease, there is a 5 compared to the placebo arm. Coming to the low volume disease, it did not show the significant benefit. So triplet therapy clearly benefit risk patients. So what is the key result from this PEACE 1 trial? What is the benefit of abiraterone? The addition of abiraterone to ADT plus docetaxel significantly improved radiographic progression-free survival and overall survival. Coming to the survival data, in high volume disease, the triplet therapy improved median OS by roughly 1.5 years compared to the ADT plus docetaxel. Coming to the radiotherapy changes, while adding radiotherapy to the primary tumor, in low volume disease, it improved the radiographic progression-free survival and time to castrate resistance, but didn't improve the overall survival in low volume patients. Coming to the safety, the addition of the abiraterone did not significantly increase the rate of severe grade 3 to grade 5, some various adverse events, though it did increase the rates of hypertension and liver. These are the main side effects we have to observe when we are adding the abiraterone plus docetaxel. So the results suggest that for patients with de novo metastatic castrate-sensitive prostate cancer, the combination of ADT, docetaxel, abiraterone should be one of the new standard of care. So coming to the second trial, which showed good results in the high volume, high risk patient is the darolutamide. This is the ARASENS trial. This ARASENS trial is the globalized randomized phase 3 study. Majority patient hormone sensitive prostate cancer. Patients are eligible, if the patients are eligible for docetaxel, then only they are included in the trial. It is a 2-arm trial, docetaxel in 6 cycles plus darolutamide. Second arm is the docetaxel 6 cycles plus placebo along with androgen deprivation therapy. So coming to the endpoints, primary endpoint is the OS, secondary endpoint is the castrate-sensitive prostate cancer, time to pain progression, time to initiation of subsequent antineoplastic therapy. These are all the secondary endpoints. So majority of patients received the 6 cycles, both groups. So coming to the survival analysis, if you see this curves, overall survival darolutamide significantly reduced the risk of death by 33%. If you see the 5-year survival, if you see the around median survival, this is around 50 months in the placebo. They didn't reach any, still median survival not yet reached in the darolutamide group. Oh, yeah. If you see the data in the high risk patients and low risk patients, in both high risk and low risk patients, it had showed the trend towards the good PFS and OS benefit. So we can see the benefit in the all subgroups like high risk patients and low risk patients. If you see the subset analysis for this placebo versus darolutamide, it showed the benefit in all subgroups, including ethnicity, including age, including previous Gleason scores and everything. In all subsets of groups, darolutamide shows better than the placebo. So coming to secondary endpoints, time to castrate-resistant prostate, also that is definitely shows the good results. If you see the median time did not reach in the darolutamide group compared to the placebo, it is 19 months. Time to pain progression also significantly better in the darolutamide compared to the placebo. Time to first symptomatic skeletal events also better with the darolutamide group. Time to next antiplastic therapy also darolutamide group compared to the placebo. So coming to the adverse events, so almost majority of adverse almost same comparison. So commonest adverse event we will see in the darolutamide is most commonly musculoskeletal. Fatigue is very, very common. Some patients have a rash. These musculoskeletal events are very, very common. Others are very, very less common compared to the other groups like enzalutamide and apalutamide and abiraterone. So coming to the PSA response, darolutamide group almost nearly 2/3 of patients, around 65% of patients have a undetectable PSA levels in darolutamide group compared to the only 25% with the placebo group. So if you see the curves, if the patient who developed good PSA response, who attained good PSA response, their survivals are very pretty better compared to the patients who didn't get any PSA response. So in DARA group, majority of patients have a high PSA response. So their survival curve is also very, very better. Survivals are improved. So if the patient had a PSA improved, if you see the overall survival also better if the patient who achieve this undetectable PSA compared to the placebo group. You clearly separate, if you see these Kaplan-Meier curves, a very, very good OS benefit. So darolutamide triplet achieved long periods of disease, long periods of no progression to disease progression, and also significant improvement in the overall survival. So what we learned from the key results from the ARASENS trial? Coming to the subsets, overall survival, the risk of death was significantly reduced by 33% with hazard ratio of 68 the group compared to the 48 months in the placebo group. Coming to the disease progression, time to castrate resistance also significantly delayed. So our final aim is finally we have reached that final aim, that is castrate resistance. Coming to the consistent benefit, the survival benefits were consistent across both high volume and low volume disease. So we can see, we can give in both high volume patients and low volume patients. Coming to the safety profile, this is the highest safety drug compared to the all hormone therapy drugs in the hormones into cancer, well tolerated, very similar incidence of adverse event compared to the placebo group. This is a very unique drug. It doesn't cross any blood-brain barrier. So it causes very, very less CNS side effects in the prostate cancer patient. Because of majority of elder patients have a majority of CNS results like seizures, falls. These are very, very common. So this drug is very high safety in that issue. Coming to the clinical impact, the combination of DARA, darolutamide, ADT, docetaxel is now established as the standard of care for patients with hormone-sensitive prostate cancer in both high volume and in high volume patients. So in high volume, high risk patients, two drugs approved. One is the abiraterone, and one is the DARA. So which one is better? There is no head-to-head comparison with the DARA with abiraterone, but there is a cross-trial comparison and real-world data. If you see, both the DARA, abiraterone, when we add it to ADT and docetaxel, highly effective triplet therapy. But real-world data suggests darolutamide may offer deeper, more durable PSA responses, better survival outcomes, and superior safety profile compared to the abiraterone. So we can give DARA combination is the highest safety and better response and better OS benefit compared to abiraterone. So deciding between the doublets and triplets, so we already discussed low volume patients, low risk patients, we can give doublets. High volume, high risk patients, we can give triplets. So patients' comorbidities, all these are very important when we are taking they can tolerate docetaxel or not. We have to all the take consideration to the final treatment outcome. So thank you.
Yeah, thank you, Dr. Muralidhar. It's a wonderful presentation. I think you have started from early days to the now. I think there is a wonderful exposition from starting to end. I think you have covered almost all clinical trials without restricting to one drug itself. So very good presentation. I think now, we can have the question and answers at the end of the session. And now I am going to present as the small data, because again, you clearly mentioned this arsenate trial, high risk, high volume. Can we give this darolutamide alone with the ADT? That is something like a low risk and low volume. That just I will go to present the one of few slides on that, because it's recently they updated their data. My slides are visible?
Yes, sir.
Hello?
Yes, sir. Slides are visible and you're audible.
Just
Please
one,
go
just
ahead.
one. Yeah, just 1 minute. Just I'll make it a present mode. Something can. It is not in the presentation mode, no?
No, sir.
Hello.
Actually, it is
Not in the
edited.
present mode.
It was in editable mode. Click on the other slide, sir. I think you will get it. Just click on other slide.
This is slide. Yeah, just okay.
No.
It
Now
should
it
be the
will be
presentation mode, no?
Yeah. Downside you can see, sir. Right side.
Yeah, just it is not. Problem is entered. Now give me 1 minute time. Yeah. Is it okay now?
No, sir.
Okay.
No, sir. I think the screen has been paused.
No. Just you can see now.
No,
Visible?
not visible, sir. Actually, it is paused. Screen is paused.
No. Okay, just again I'll stop sharing. Again
Yeah.
I'll do that one.
Yes, sir.
Again I'll try to share this one. Okay.
So now you can see the full screen mode.
Slide. Just, it is not the full screen, no?
No, as of now, not, sir. The downside, you can see the cup handle.
Yeah, just problem is just it's I
The
am.
fourth symbol, sir,
Oh
from
yeah,
top.
just this. Yeah. It's
Now it
okay
is.
now.
Yes, sir.
Okay.
Now it is full screen, sir. Yeah, please go
Yeah,
ahead, sir.
thank you for thank you, Murli, and for a wonderful, I think, introduction. And you have given all the something like clinical trials. I think this is summary slide of most of the clinical trials where we started. Initially only ADT, only androgen deprivation therapy. Then started again the docetaxel. Initially it was the mitoxantrone, but later the docetaxel entered the picture in 2014. But docetaxel again they are given to the patients for high volume. So again, each trial has its own definition based on the number of metastasis and visceral metastasis. You can clearly see stamped latitude, stamped abiraterone. They have included, I think, Dr. Murli clearly mentioned abiraterone, enzalutamide, apalutamide, all the trials he mentioned in this one. Coming to the RSNs also is clearly explained the what is the advantage of adding the docetaxel to the ADT plus darolutamide. So this is specifically for again hormone sensitive prostate cancer. Just you can remember that is a hormone sensitive. That means de novo metastatic prostate cancer. So that is, I think, these are the clinical trials. The well explained by this Dr. Murli. I am going to touch upon this RN8, okay, this darolutamide plus ADT. So because both the regimens are approved, but which one do you want to choose based on this again? The volume of the disease and burden of the disease. So there is an unmet need, but sometimes sometimes we can't give the docetaxel to certain patients because of there is no high risk disease or some absolute contraindication elderly. So still, is there any possibility to give the only darolutamide plus ADT? This trial I think started long ago. So now I think I clearly mentioned the R&D is designed to evaluate darolutamide plus ADT to provide a new treatment, whether it is without docetaxel can be given or not. So ultimately, this is the clinical trial design. So it's a confirmed disease with visceral metastasis, and this visceral present or absent. Next one is the prior local therapy in the form of surgery or radiation is underwent or not. You can see clearly this darolutamide 600 mg BD, okay, plus ADT, the plasma plus ADT. The primary endpoint of this trial was PFS. Okay. The second endpoint was OS. So many endpoints are there. Time to initiation of subsequent antineoplastic therapy, time to CRPC, time to PSA progression, rates of undetectable PSA, time to pain progression, safety, and ultimately there are so many subsets are there. Okay. But whatever this treatment we give, the quality of life also most important. The quality of life is assessed with a FACT-P scoring system. Okay. So these are baseline characteristics. I think you can see race, religion, or region, EGOG, performance status, Gleason score, disease volume measurements. All are well balanced between these two arms, darolutamide plus ADT versus ADT alone. So country-wise also, I think clearly this is a multi-center trial and all regions of the world is involved in this one, including India and China, Asians and other Caucasians, whatever you take it. But this darolutamide plus AID significantly reduce the risk of radiological progression or death by 46%. You can see clearly here around, okay. So around 46% versus placebo, 70.3 versus 52. Okay, hazard ratio, there's a 0.54 because of death by 46%. Coming to this again, this median of PFS not reached, okay, at 24 months in darolutamide plus ADT arm, but it's reached in the ADT arm alone. So you can see again these other subgroups also. So age, baseline characteristics, okay, especially this PSA value, performance status, Gleason score, disease volume, race, but whatever you take it, just you can right side of this again slide, you can clearly see that. Okay. Right side of this one is you can clearly see there is a definitely there is an improvement in all subsets. There is an improvement in more in favor of darolutamide. So the hazard ratio for this one also, this one. And we clearly mentioned that irrespective of the disease volume also, but I think we want now this is a standard of care. I think what you said is clearly low volume. We can see a more significant difference in the low volume disease, not in the high volume. Okay. So with this DARA, ADT was demonstrated in time to metastatic CRPC, time to PSA progression, time to initiation of subsequent systemic therapy, time to progression. Whatever you take it ultimately is more in favor of darolutamide. Okay, so time to metastatic CRPC clearly you can see here. So time to pain progression, there's a clear-cut difference between these two arms. Okay. And ultimately, the PSA, just what you mentioned, undetectable, poorly clearly mentioned. So 62% versus 18. Okay, so the plus 82 plus you can clearly here you can see this one time to PSA progression, but the next line of therapy. So again, the hazard ratio 0.31. You can imagine this. So much of benefit by adding darolutamide to the ADT alone, even in the low risk, low volume disease also. High volume, you can see some benefit, but low volume, you can see the significant difference between the ADT versus ADT and darolutamide. So ultimately, patient's subsequent life-prolonging systemic antivenom. Whenever we are talking about this multiple lines of therapy, you have to think of the next line of therapy also. The next line of therapy is here is clearly. So that's when to start the next line of therapy. That's also one of the endpoints of any clinical trial, 32.2, and there is also when they decrease significantly. And incidence of again treatment-related adverse events, not many, even though it has some side effects, but darolutamide is well tolerated without any major side effects. You can see any adverse event 90.1% to 90. So grade 4 events also very low. So almost nil, I think you can say that one. So rates of most common adverse events were low in, you can see anemia, arthralgia, UTI, whatever you take it, except fatigue. So remaining all are similar. So one thing is just we have to careful about this hypertension because it sometimes it causes hypertension. So be careful about this one. And it extend median time to deterioration of fact. This whenever we are talking about this advanced disease or stage 4, we have to talk in terms of efficacy or quality of life. That is known as something like any other quality of life assessment. Here is by fact P, a total score by 5.1 months versus this 5.1 months benefit is there. So definitely you can say time to deterioration, the fact P score. So whatever you take it in the form of efficacy, PFS, okay, and this quality of life also definitely better. With this, they again this forest plot. You can clearly see this one: social well-being, emotional well-being, and functional well-being, urinary symptoms. Whatever you take it, all in more in favor of the darolutamide plus ADT. So darolutamide ADT significantly improved PFS in patients with metastatic hormone sensitive prostate cancer. It showed a benefit across all secondary endpoints. Darolutamide was with the deep PSA response and pain progression also more in favor of DARA. Overall well-being also, this what you can say quality of life. So darolutamide had a favorable safety profile also. So if the patient has a low volume without any measure, something like in a bone metastasis, visceral metastasis, still you can think of without docetaxel, darolutamide alone will give us a better survival, better quality of life. So think of that in summary. In these two presentations, high volume go for darolutamide plus docetaxel plus ADT. In low volume patients, elderly, if you don't want to give the docetaxel, still we can consider darolutamide as a single therapy. Darolutamide plus ADT without any docetaxel. Thank you. Just again, I'll hand over this podium to Dr. Rajni. She is going to share her experiences. Sorry, just my voice is not at all clear. I am a little bit bored. Sorry. So, Dr. Rajni, over to you now.
Yes, sir. Thank you. Sandeep, can you share the PPT?
Yes, please give me.
So thank you, sir. So we have learned, as you have rightly said, for high volume disease, we'll go for the triplet therapies, especially ADT plus docetaxel combining with the darolutamide is more safe with a better quality of life than comparing with abiraterone, which comes with many side effects. And in high volume disease, and coming to the low volume disease, definitely eight doublets are the way to go. So ADT with darolutamide with improved survival and with better quality of life is a treatment of choice in these patients. So coming to the case presentations which I'm going to discuss. So we have 3 patients. So all the 3 patients are high volume disease patients. With different scenarios, like how darolutamide produced response in those patients. So, Sandeep, it's taking time. Darolutamide, we know that it is a second generation newer anti-androgen. So with a unique structure and with a better safety profile, when we think of enzalutamide, we are more concerned of the CNS side effects like the falls, the seizures and all. So especially in elderly patients, these prostate cancer patients who are elderly, we are more concerned of these CNS side effects. And coming to apalutamide, it is known to cause rash and hypertension. So this darolutamide, which is safe, so we have less CNS side effects, which have less incidence of rash, hypertension, and all. But fatigue, it's not very severe. It's a manageable side effect with less drug-drug interactions compared to other anti-androgens like enzalutamide or apalutamide. So especially these elderly patients who are on polypharmacy with multiple comorbids and all. So having an anti-androgen therapy with less side effects, with less drug-drug interactions is really a boon for in treatment of these prostate cancer patients. So coming to the case presentations, first case. So next slide. So we have a 77-year-old male patient who has multiple comorbids, like he's a diabetic, hypertensive, with CAD and CABG was done in 2000. But he is an ex-serviceman, so he's in good performance status, nutritional status is well preserved. He presented to us with a lower urinary tract symptoms. Next slide. So he was evaluated by the urologist. Trust-guided biopsy was done, which was suggestive of a prostate SNR adenocarcinoma. And his baseline PSA in October 2025 was 349. And the Gleason score is 9 with a grade group of 5. Next slide. So we had done PSMA PET CT scan, which showed metastatic disease with multiple bone mets and nodal metastasis. Next slide. So he is classified as a high volume metastatic castrate sensitive prostate cancer. And for this patient, we started on the triplet therapy because though he has multiple comorbids, his performance status is good, nutritional status is good. And given the high volume disease, we went with the triplet therapy. We started with the ADT, that is relugolix, which is an oral form of anti-androgen ADT, androgen receptor antagonist, relugolix. So along with that, we gave him docetaxel. We gave him 3-weekly docetaxel at a dose of 75 mg per meter square, along with darolutamide, which is given at a dose of 600 mg BD. Next slide. So this is based on the Erasmus trial, which has clearly shown to have survival benefit in high volume disease patients. So if you can see the fall of the PSA levels at October, it is 349. Within 1 month of starting of this combination, you can see there is it is almost 0.9. And every month, if you can see that it has consistently well below the detectable range. So it's almost 99% PSA decline we had seen in the 6 months of his treatment. So at end of 6 cycles of docetaxel, we had done PSMA PET CT scan, which was suggestive of near complete resolution of all the previous sites of metastasis. Next. Next slide. So coming to the toxicities, he had no much toxicities with chemotherapy or darolutamide. He tolerated the treatment very well. So he had symptomatic relief at the very first cycle of treatment with a good PSA decline, as we have seen. And even the PET CT scan was also suggestive of a near complete response. Next slide. So you can see such a high volume disease, it's almost near CR in the PET CT scan. So this is what we have already discussed. So it's a well tolerated regimen. It's really surprising for me to see a elderly 77-year-old male tolerating chemotherapy, ADT and darolutamide with no much grade 3, grade 4 toxicities. So the learning points from this case is darolutamide based triplet regimens especially produce a rapid and deep PSA responses, and it can the manage with no much added toxicities even in elderly patients with cardiac comorbidities. So if you take the triplet regimen like ebratarone, definitely in a patient with hypertension, diabetes, with patient with CAD patients, really difficult for us to manage with the toxicities in addition to your docetaxel. So, but this darolutamide helps us overcome all these toxicities in these elderly patient subset of patients with cardiac comorbidities, especially. Next slide. Next slide. So this darolutamide-based triplet regimen had resulted in rapid biochemical response. You can see within 1 month of initiation of the regimen, from 369, it has almost come to less than 1. So there is deep PFS suppression with near complete metabolic response on PSMA PET with excellent tolerance in this elderly patient. So this real-world scenario reinforces the ERASENS trial outcomes. Next slide. Next slide. So this is the second case. Next slide, please. So we have a 66-year-old male patient who presented with lower urinary tract symptoms. His presentation, his PSA presentation is 200. Next slide. Next slide. Sandeep.
Ma'am, it is take some time.
So,
Vaccine.
yeah, definitely. So the prostatic biopsy was suggestive of a prostatic adenocarcinoma with a Gleason score of 9. So if you can see the PSMA PET CT scan, this is also a high volume disease with multiple non-regional nodes and also multiple skeletal metastasis. So it clearly classifies our definition of high volume castrate sensitive prostate cancer. Next slide. So this patient was started on Degarelix, 240 mg, that is the loading dose, followed by 80 mg monthly. So initially he received only docetaxel at a dose of 50 mg per meter square. This is given every 2 weekly. And we started him on darolutamide after 2 months of starting the docetaxel. So initially, because of some logistic issues and all, we couldn't start from the very first cycle. We started after 2 months of this ADT and docetaxel. Next slide. So if you can see the drop of PSA, so from baseline 200, next after initiation of within 1 month of initiation of darolutamide. So we have already discussed, we started darolutamide after 2 months of the therapy. So you can see the very 1 month of starting of darolutamide, it has come to 5.9. And after 5 months, it's 3.4. So this patient also tolerated this triplet regimen well with no much toxicity issues and all. Next slide. PET CT scan also had shown significant response to treatment with near complete response of the previous visualized metastatic sites. Next slide. So this we have discussed. Next slide. This shows that addition of darolutamide had resulted in a very drastic decline in the PSA level and near complete metabolic response on the PSMA PET CT scan as well. So even though there is a delay in initiation, darolutamide is a wonderful drug which had resulted in a rapid and deep PSA responses. Next slide. The patient is continuing darolutamide and he's doing good. Next. Next, coming to the third case. So this is a 58-year-old male patient who presented with lower urinary tract symptoms, and he has a PSA of more than 100 at presentation with bone mets at presentation. So this patient has a Gleason score of 9. So he is also a high-risk metastatic hormone-sensitive prostate cancer patient. Next slide. So this we have discussed based on the criteria of the latitude and the charted. He qualifies as a high risk and high volume disease. Next slide. So this patient was started on darolutamide and relugolix. So the PSA decline was very fast. After 2 months of treatment, PSA was 0.5. After treatment completion, PSA was less than 0.1. Next slide. So if you can see the PET CT scan after the triplet regimen with the darolutamide, chemo, and the relugolix. So next slide. The patient responded very well to the treatment, but unfortunately, because of logistic issues, he had to stop darolutamide. And within a few months of stopping of darolutamide, that is almost 2 months of stopping it, the PSA has again started to increase, and even PSMA PET scan was also done, which was suggestive of a progressive disease. So we had to restart the darolutamide again, and the patient responded very well after reinitiation of the darolutamide alone. And the patient is now continuing darolutamide. So this stopping of darolutamide and reinitiation has also resulted in a good response in this patient. Next slide. So next slide. So finally, to conclude, in this case represents a high volume, high risk metastatic hormone sensitive prostate cancer patient where triplet regimen was started, and it has resulted in a rapid deep PSA response of less than 0.1 with significant radiological improvement in the initial phase. But because of treatment interruption, there has been an increase in the PSA again with the radiological progression also, highlighting the critical importance of the continuous androgen axis suppression and the aggressive biology of the high-risk metastatic hormone-sensitive prostate cancer. Rechallenge with darolutamide again resulted in a PSA decline, reaffirming that persistent androgen dependence, ongoing role of targeted therapy even after temporary discontinuation. So that's it. So these are the 3 cases, and very recently we have one more case similar to what Sadasivdu sir has suggested. We are giving the doublet in one patient. So that patient is a very elderly patient, 85-year-old patient with multiple comorbids. He came on wheelchair, performance status was poor. So though it's a high risk disease at presentation, we had to start him on just doublet regimen. So given his all comorbids, had to choose darolutamide. So the patient is on darolutamide and relugolix, and within 1 month of starting off the darolutamide, the PSA had dropped from 130 to almost 0.9. So the patient also is doing clinically well. So this is how darolutamide is resulting in a very rapid decline in PSA and symptomatic control with no much added toxicities and improved quality of life. So darolutamide combinations, be it with chemotherapy or without chemotherapy, either as doublets or triplets, are really a boon for many of the prostate cancer patients, especially elderly patients with polypharmacy and comorbidities. Thank you, Sadasivdu sir, and thank you, Bayer.
Yeah, thank you, ma'am. I think I can't see sir is not there if I'm not.
Yeah. Oh,
Give me a minute,
so
ma'am. Let me check
yeah.
with sir. Is there any technical issue or maybe I'll come up. Okay.
So we have data for all the three indications: non-metastatic CRPC. We have in high volume disease as triplet. We have and also as doublet. So previously we were like concerned because a good drug with no side effects, we don't have data to give it as doublet. But now after the Aronet trial, we have the doublet data also available. So I think many of the patients will benefit.
Ma'am, sir is joining in a minute. I think there was some technical issue. It was disconnected.
Yeah. Okay. I think we can ask Murli sir to share his experience as well.
Rajni, well presented, very good cases actually. So actually, I don't
Yeah,
have
hello.
any data
Yeah.
cases actually.
Okay,
Hello.
sir.
Yeah, sorry, thank you. Just suddenly I disconnected because of some urgent misconnection because I am sitting in a car. So some problem. Okay. Hello.
Yes, sir. Yes, sir. Yes,
Yeah.
sir.
Yes, sir. Done, you're done.
Yes, we are done with the case presentation, sir. Yes.
Yeah, I think I can say the only closing remarks. So I
Yes,
think,
sir.
as I mentioned, I think this very interesting area is one is clearly we have the two options now. One is without docetaxel and with docetaxel. We have the clinical data for the both. I think any high risk as well as low risk. So any of the other what you can say participants they can ask any post any questions in this. Otherwise, we can conclude the session. Thank you for the Bayer for giving this opportunity. Sorry, just I was a little bit busy and just I was driving and that's all. Okay.
Thank you,
Hello.
Okay,
sir.
sir. Yes, sir.
I'm in the
Yeah,
car only, but not driving. But again, the car outside of the. Okay.
sure.
Sorry.
Okay, sir. Okay, sir.
Done? No
Before closing,
questions.
let me check this.
No questions.
Yeah, I'm just checking the chat box, sir. Let me check.
Yeah. Okay. You can mention your vote of thanks.
Yeah,
Thank you, Dr.
I
Murli.
don't
Thanks.
see
Yeah.
any
Yeah.
questions in the chat.
Yeah.
Yeah,
Okay.
please go ahead, sir.
Yeah. Thank you, Dr. Murli. I think first time I think after a long time and we listen your talk and you very nicely presented the data. But as usual, Dr. Rajni she's a very good speaker. So I no need to
Yes,
mention
sir.
that one. She's very good speaker and she's very good writer also. So thank you for both of you and thank you for Bayer to giving this opportunity. Thank you very much. Bye bye. Good night.
Thank you
Thank
Over
you
to
so
you.
so
much, sir. Bye
Over
bye.
to Bayer. Sandeep. Bye bye.
Thank you
Thank you,
so much,
Murli
sir,
sir.
for your
Thank you,
time.
Sada sir. Thank you, and Bayer.
Thank you, Rajni.
Thank you,
Bye bye.
Sandeep. Yeah, yeah. Bye, bye, sir. Good night.
Thank you, ma'am. With this, we can conclude the session. Thank you.